Mike, if you want to come on up here. So this is Mike Gilchrist. He's a medical student working with me, 4th year. He's going into family medicine and sports medicine. So he's going to start us off with some patellofemoral disorders, and then we'll move forward from there.
Next slide. Thanks, Dr. Juelson. Like you said, my name is Mike Gilchrist. I'm originally from Bismarck, but I've been up in Grand Forks for the last few years. Came back here, so I'm just going to do a cruising altitude view of patellofemoral disease, hopefully in the time it takes for Tiger to not get another bogey at Augusta. So
we have a bonus slide here. You may recognize somebody here from last evening.
What? That first slide on mine.
Oh, in yours? Okay, give me 1 second. There you go.
So very quickly, just going to go over the relevant anatomy of the patellofemoral joint and then some of the more anatomic variants that will cause chronic instability at that surface. So looking at the medial superficial knee capsule, most relevant structures here will be the medial patellar retinaculum. This is all the stuff that's superficial to the superficial MCL. When we're getting into the second layer, that'll be where the superficial MCL hangs out. This is going to be our primary restraint against valgus stress, as we all know. And between the second and third layers is where the MPFL, or the medial patellofemoral ligament, hangs out. Also the posterior oblique ligament. The MPFL sits between the second and third layers, and so these two have to be teased apart when an MPFL is being reconstructed. And then deep to this, in the deep layers where we have the deep MCL, that's going to do more of a secondary restraint against anterior tibial movement, kind of in support of the ACL than to valgus stress. Shifting back to the MPFL itself, it originates between the medial epicondyle and the adductor tubercle of the femur and inserts on the superomedial patella, and it keeps that patella center within the trochlea, most notably between 0 and 30 degrees of knee flexion. The range, depending on anatomic variation, is between 50 to 80% of restraining force that is keeping the patella centered. And as I'll get into, the skeletal anatomy beyond that and the shape of the trochlea contains the patella within the trochlea with any more knee flexion. With any sort of MPFL deficiency or injury, there's also going to be skeletal damage and other soft tissue damage. You can have tearing of the vastus medialis obliquus, tearing of the retinaculum, but more notably, you're going to have damage to the lateral femoral condyle and the facet of the trochlea, with medial patellar damage as shown with the stress reaction on this MRI. The mechanism of most commonly how you acutely tear this ligament, as shown by my cartoon buddy here, is a sudden quad strain with a knee that's partially flexed, valgus stressed, and somewhat externally rotated. Obviously, this is going to be very distressing to patients because sometimes they just don't lose back, and so they'll have a lot of pain, and the shock of it all happening can be very distressful, as this patient of Dr. Juelson's would attest to, especially with the X-ray findings as well. On this MRI for the patient, you can see that on the top left corner there, the MPFL is shredded down to nothing, as we don't have any good black continuous tissue. As far as patterns of dislocation, we can have acute, recurrent, or habitual. With recurrent, there's a ton of risk factors, namely bilateral disease, female sex, second decade of life, and just general hyperextensibility amongst several others. And there's habitual dislocations where it's coming out every time you flex and returning to the midline every time you extend. So the early arc and knee flexions, where the MPFL is doing most of its work. Beyond that, when all of these other issues come into play and put patients at risk for chronic instability. Very quickly on these, one is increased femoral anteversion. If you draw this line in the axial plane between the head and neck of the femur and then the trochlea of the femur, If you have an anterior tilt to the distal femur, you're going to have a lot of different things happening here that put you at risk for lateral patellar subluxation, namely an excessive lateral force, dysplasia of some of the quad tendons due to the excessive Q angle because of how the femur is anteverted. A quick note on TT-TG distance. Good indicator for prognosis in the long term after an MPFL is fixed, but as an isolated factor, not too much to worry about as an isolated indicator just because there's so much other stuff at play here. More importantly is trochlear dysplasia. So be it pre-surgical or post-surgical, it's significantly more frequent in surgical failure groups than control groups, and there's a huge risk of osteoarthritis over time. So dysplastic trochleas are going to be shallow, flat, or convex, and because of all these weird shapes, you're going to have less efficacy in restraining that patella within the trochlea in those later arcs of flexion. This is the de jure radiologic classification, A through D. The punchline is that if you see on x-rays that a trochlea is either shallow, flat, has asymmetric facets, or a combination of the three, your patients are going to be set up for a lot of troubles with dislocation in the long term. Combine this with a high comorbid occurrence of patellar malposition, you're even worse off. Less frequently you see patellar baja or low position of the patella. This could be due to tear of the quad tendon. More often it's a length discrepancy. Patella alta is far more common. It's present in about a quarter of patients with acute dislocation, and just you can think just structurally you need a greater degree of flexion to engage that trochlea, so you have reduced patellar contact area in early flexion. So it can present by itself just as an isolated factor, but more often than not you're going to have trochlear dysplasias to go with it. High comorbid condition. And then very briefly, before I get to Dr. Juelson, is just generalized hypermobility. In addition to patellofemoral pain syndrome being more likely, you're going to see a lot of patients that have recurrent dislocations if they have just general hyperextensible joints. This is where the past medical history comes into account a lot because you're thinking about things like Ehlers-Danlos, Marfan syndrome, and the like. That's all I got. Nothing to disclose for me. That probably will change after I talk to B&D about loan repayment, but that's all I got.
Thanks, Mike. Great job. So, two things. Number one, we'll do it at the same time. We need to give Mike a round of applause, but we also give Kevin a round of applause for organizing this conference. He's put a tremendous amount of time into this. He was able to do that at a time that he was having total knee arthroplasties, and so he's had a lot going on. Did a tremendous job, and so we appreciate all the work you've done, Kevin. So we're going to move on with patellofemoral management, and if there's any questions at any point, please feel free to speak up at any time here. So Mike went through a few of these things, but keeping in mind the patella, it is a sesamoid bone. It's the largest in the body. It also has the thickest articular cartilage, up to 6 and sometimes even 7 millimeters thick. So that's important when we're considering articular cartilage restoration in getting back to that articular cartilage depth. It also has ramifications that you can't take part of the knee and transplant into the patella and have success, because we have then basically graft bone mismatch and some other issues. So just something to keep in the back of your mind. So there's multiple facets within the patella itself, and the patella is highly variable, highly unique. So there, again, some patients have 3 well-defined facets. Some people have many more than that. They are all rather unique in most cases. So here's just some examples. Just like our bodybuilders, there's some variation. So Lieberg classification, we realistically we use that when we're looking at fresh OC articular cartilage transplant. We have to classify using that because that's what most of the tissue banks are still using. Otherwise, it's probably not going to be clinically important for you. As Mike had already discussed, the trochlea is very important. This is a drawing here, an intraoperative drawing, or an intraoperative photo. It was on a patient who's about to have a trochleoplasty. So it's something that was very rarely used. There was a few people in the world doing these. Now there's a few more now that Arthrex has some devices that make it a little bit easier. But we still don't have long-term data on this. The previous data was either extreme disaster or slightly improved slight improvement over a number of years. So most of us have stayed away from this due to the unpredictability of the results. This may be improving, but it's going to be still multiple years until we have some actual data on that. So that's still kind of more of a last resort. So one thing to also keep in mind is if you can conceptualize the patellofemoral joint more so as the femur articulating with the patella, things will make a lot more sense and be a lot more logical as you're trying to think about stability, the articulation, a number of other things. So oftentimes we think about it in the opposite manner, and that makes it a little bit more difficult as far as improving the articulation there. So again, thinking about the femur articulating with the patella. So we went through the various structures here earlier. Lateral retinaculum is very important. We know it is also a restraint to lateral translation. So be cautious with that, and it's also one of the reasons why we rarely do isolated lateral retinacular releases. So oftentimes they'll be used in tandem with other procedures. But patients who are hypermobile and have a lateral release, their results in the literature are very poor. They tend to have rapid increase in the dislocations and instability. So that's the one group in particular that should not have an isolated lateral release. So hypermobile and lateral release should not go together. And these are in your PowerPoints. We're just a bit behind here, so you're welcome to review these. We're going to move towards a case here. So again, looking at trochlear dysplasia, this is a quadriceps active view here. So joint reactive forces, keep in mind, tremendous joint reactive forces through the patellofemoral joint. So as has been mentioned already during this conference, somewhere in the range of 7 to 8 times force just with body weight squats, stairs. Now if you place high velocity impact loading into that, we're well into the high teens with joint reactive forces across the patellofemoral joint. So tremendous amount of force through a very small amount of joint, very small contact surface area. Femoral anteversion has been covered. So history is very important with these patients, and oftentimes just listening to them, they'll frequently tell you what's wrong, as has been mentioned here. And then the number of dislocations typically is going to be very important. So typically anything past 2 dislocations, we try to stop that from occurring due to the increased risk of long-term arthrosis and so forth. There are many surgical options. There are some surgical options that we use more frequently, which have fairly good long-term results. But again, caution with respect to isolated lateral release. So there's many other historical things, VMO transfer. We don't do these anymore. So the VMO transfer kind of was penalizing patients twice. So first, work on the VMO, which is not able to be selectively strengthened because the neural impulse comes from the spine, which then travels to all 4 components of the quadriceps. So selective VMO strengthening there isn't any data to support that is effective or is even physiologically possible. So in these patients, they were supposedly selectively strengthening their VMO, and then when that failed, then their VMO was cut off and moved around. So they were penalized twice in this case. So we don't do this anymore. So moving forward, rehab again for anterior knee pain is largely going to be related to hip and core strength. Quadriceps strength is still overall helpful and important, but it is just a component of that rehab. It is not the mainstay. So we will get through part of this video here. This is a patient. So this is a patient who is both malaligned and has patellofemoral instability. So we're addressing the malalignment from the tibial tubercle. So this patient is having a tibial tubercle osteotomy, essentially a anteromedializing procedure, and then also medial patellofemoral ligament reconstruction. So there are multiple ways to treat this. There are bigger options for this, but we don't have a whole lot of literature on it. In some centers, in some places, the best outcomes have been found by actually derotating the tibia and the femur. So that's 2 separate osteotomies. And the first procedure typically is high tibial derotational osteotomy, which is also going to alter where the foot is pointed in gait, and then that in turn, later typically a derotational osteotomy of the femur is performed in external rotation. The tibia goes in internal, the femur in external, and now the trochlea and the patella truly are aligned. But that's a pretty big deal to start looking at rotating both the femur and the tibia, 2 separate stage surgeries. So that is done only in a few centers, and we have limited data on that. So this was popularized by Dr. John Fulkerson out of Connecticut a number of years back. We have a lot of data. We have good long-term results with when the alignment is problematic. If the patient purely has isolated instability, then we can treat that in a manner basically where we are just reconstructing the medial patellafemoral ligament, and that can be done in a couple of different ways. Right now, we're typically using an allograft and anchoring into the patella and into the femur, and have had very good results with that. There's also another way to do the same thing that Dr. John Fulkerson has recently started working on. We have some data where we don't have to place as many bone tunnels, but that is still early. Any questions so far? We will just fast forward this a little bit here.
If you want to fast forward, you'll skip to the next slide.
Let's just skip to a couple of cases here. So any questions? So 18-year-old female, she has had multiple lateral patella dislocations. In that image, you can see that she has moderate trochlear dysplasia. She has patella alta, kind of the classic findings. She's hypermobile, and she has failed non-optimum measures. She's tried both bracing, extensive formal physiotherapy, rest, time. And so here is just here's her trochlea, of which you can see she has minimal trochlea. She has a very slight supratrochlear prominence in the proximal part of the trochlea. And then here's her tibial tubercle. So you can see that central tibial tubercle relative to the trochlea, and she's substantially lateralized. This is articular cartilage gone from the medial and central ridge of the patella. So this is post-op, so tibial tubercle osteotomy, in addition to medial patellafemoral ligament reconstruction, of which you can just see bone tunnels here. So in that video, we did show MPFL reconstruction, but due to time constraints, we will move forward. So, and then in other cases, we address the articular cartilage. So people with full thickness articular cartilage lesions on the patella, even with adequate stability and alignment, tend to have good short-term results and poor mid and long-term results. So in particular in young people or high-demand patients, then we look at articular cartilage restoration also. And so here is one of our cases. So this was a multiple lesion case, medial femoral condyle and patella. So this was ACI. So we use a different technique now called MACI, which is just piggybacking on some of the same technique that some of us had already been using. And now it's just officially FDA approved. So we're not talking about unapproved off-label use anymore, fortunately. So otherwise, MPFL certainly tends to be the mainstay of treatment with patellafemoral instability, and then alignment is addressed on a case-by-case basis. It truly depends on, every patient is treated individually with this. It depends on three major components, both stability, alignment, and articular cartilage. So if we leave one of those out, we tend to compromise mid and long-term results. So all three of those things, stability, alignment, and articular cartilage, should be addressed in most or all cases. And then in some cases, we can only address one or two of those, depending upon the degree of damage and the stage of life that people are at. Any other questions? Comments?